Good evening, and welcome to the first session of our three-part webinar series on pelvic endometriosis, sponsored by the American Institute for Minimally Invasive Surgery, their educational division. Firstly, tonight we'd like to give thanks to our sponsor, Sumitomo Pharma. Without your help and dedication to furthering education, we wouldn't be able to put this program on, so we thank you very much. My name is Dr. Tamberly McCarris, and I'm pleased to serve as the moderator for today's program. I am especially grateful to AIMIS for sharing this educational session and helping bring together experts dedicated to advancing the care of patients with endometriosis and chronic pelvic pain. The focus of today's webinar is the evolving approach to early-stage endometriosis, with particular attention to outcomes in patients experiencing chronic pelvic pain. Our objectives are to explore the relationship between early-stage disease and pain symptoms, review current diagnostic protocols for endometriosis, and discuss the important paradigm shift from relying primarily on surgical diagnosis towards accelerating and streamlining the diagnostic workup to facilitate earlier intervention and improved patient care. Today's agenda consists of two presentations. Dr. Hannah Lewis, will discuss early-stage endometriosis, differential diagnosis with workup. And Dr. Stephen McCarris will follow with a lecture discussing early-stage endometriosis, pain management, and best practice guidelines. We're fortunate to have these speakers join us this evening, and we encourage all of our participants to submit questions throughout the webinar discussions using the chat feature. We will collect these questions and address as many as possible during the discussion period at the conclusion of the presentations. Your participation is an important part of making this a productive and engaging educational experience. Thank you for joining us. We appreciate your commitment to advancing the care of patients with endometriosis and chronic pelvic pain. And now I have the pleasure to introduce our first speaker, Dr. Lewis. Dr. Hannah Lewis is a fellowship-trained gynecologic surgeon currently practicing in Winter Park, Florida. She completed her residency training in obstetrics and gynecology, followed by an advanced fellowship in minimally invasive gynecological surgery with a pelvic pain specialty at the Orlando VA healthcare system. Dr. Lewis brings extensive expertise in the diagnosis and management of endometriosis and chronic pelvic pain. Dr. Lewis, the floor is yours.
Thank you so much, Dr. McCarris. So I just wanted to say welcome, everyone. Thank you so much for this opportunity. I hope we will learn some things together and hopefully be able to provide some good clinical pearls for everyone in their practice moving forward, and that we'll have a great discussion. So my title of my presentation is Beyond the Lesions, Mechanism-Based Approach to Chronic Pain in Early Stage Endometriosis. We're going to just, I have no disclosures relevant to today's address. So specifically, some of the objectives from my talk that I hope you'll be able to take away from. First, at the end of the talk, I would like for everyone to be able to first describe the pathophysiology responsible for pain development, particularly chronic pain development in early stage endometriosis disease. We will touch on the limited correlation between the current endometriosis staging guidelines and pain severity that patients are reporting, as well as effect on quality of life. Be able to better identify the most common overlapping pain conditions that coexist with pelvic pain and endometriosis, and be able to just have a higher suspicion for these and other diagnoses that may be at play. We'll take away kind of a mechanism, a pain phenotype-based approach to help you better evaluate these patients with chronic pain and guide therapies. And then lastly, when surgery is appropriate, we'll touch briefly on how my recommendations for counseling patients realistically about outcomes expected after surgery. So starting with the clinical case, just to set the scene, I know this is a talk not about surgery, but sometimes we seek patients for second opinions after surgery. And in this case, this is, I'm sure, someone that we've all seen before. We have a 28-year-old G0 who's coming to you with really just severe debilitating pain symptoms. She's noting dysmenorrhea, chronic dyspareunia, dyschezia, among other symptoms. She underwent a laparoscopic endometriosis resection surgery performed by another physician, which revealed pathology-proven stage 1 endometriosis, but she's still having pain. And so she's coming to you seeking a second opinion. So what we'll do, kind of start with the framework of this talk is the clinical paradox, particularly with this patient. So first you may ask, why is her pain so severe despite stage 1 or quote, minimal disease? Why do some patients with stage 1 or stage 2 endometriosis present with such severe pain, whereas a stage 3 or 4 endometriosis patient may be asymptomatic? With that paradox there. How do we know her pain is from endometriosis and not from other pain generators? And when should we suspect these other pain generators, and how we can better evaluate these in our workup? So first, endometriosis staging. You know, there are many different staging systems that are at play, and they all have their valid roles. But overall, there's been limitations with all of these staging systems. And the biggest limitation is that they weakly correlate with actual symptoms, pain severity, and quality of life for patients. And we have yet to really develop a great system that takes these things into account. We know that the EFI staging system is great for fertility outcomes, Enzian better for deeper infiltrative disease, and then our more surgical complexity or surgical finding staging systems. But none of these necessarily reproducibly account for patients' pain and the effect on quality of life and how severe these symptoms may be. We think that a lot of these systems, or the staging systems rather, and why they fail in this regard is that they may fail to account for things that are not easy to assess objectively. Peritoneal inflammation, potential nerve involvement, the presence or absence of central sensitization, and other chronic overlapping pain conditions and pain generators that also can coexist with endometriosis. So before we talk specifically about endometriosis-related pain, I just want to recap and explain the three main types of pain mechanisms and how pain we believe is most commonly generated and perceived by patients. The most classic type of pain is nociceptive pain. And this is when we have viscera or tissue injury. So whether the uterus, the bladder, the bowel, some sort of visceral organ that becomes injured or inflamed, or an actual tissue that becomes injured and inflamed. And this, the reaction and the inflammatory mediators and the reaction activation of these nociceptors then causes a pain response. So this is the most classic, well, like I say, type of pain when you actually think there's a structural lesion, fibroid-related pain, adenomyosis-related pain, or endometriosis, particularly in the early stages. Another type of pain that we see as gynecologic providers is neuropathic pain. This is a little bit different, sometimes might be a little bit harder and less discrete to identify, but this is also caused by an injury or inflammation to the somatosensory system, though, so different than just the viscera or tissue. Most commonly, we may see this involving the pudendal nerves, the ilioinguinal nerves, genitofemoral nerves, particularly in the setting after pelvic surgery or laparoscopic surgery. And this is that classic, pathognomonic, burning, tingling, numbness type pain that may be a little bit more discrete or a little bit different than our first type of pain. And then lastly, where the lines get a little bit blurred is what we describe as nociplastic pain. So typically, patients with chronic pain develop or start with a form of or an instigator of nociceptive pain and or neuropathic pain. But over time, when this is very chronic and ongoing, we see that these patients oftentimes will develop a form of nociplastic pain, where their pain perception and the way that their body is processing and interpreting this discomfort is amplified. Think of it as turning up the knob on the volume or an amplifier with with a guitar. We think that the central nervous system, the way that they are processing this pain, is either amplified and or the descending inhibition from the brain is lost in these patients. And so this is really when we'll talk about the way that they're describing pain can be a little bit different and less discrete, less common than what we're typically used to seeing as providers. So first, we'll talk about some of the way that we believe pain is generated in early stage endometriosis with lesions. So the most classic teaching and what we all know is that when endometriosis lesions and inflammation occurs, we see a neuroinflammatory state. This is very common with all types of dysmenorrhea. These inflammatory mediators are then upregulated with release of macrophages, mast cells, interleukins, and other types of cytokines. And with these all upregulated, this can contribute to that very classic kind of inflammatory pain. And something to keep in mind is that even lesions that are very small can still cause these same inflammatory markers in this response. So even microscopic lesions at this time can be very biologically active and affect the entire pelvis. We also know that in some lesions, there can be a neuroangiogenic component too, so release of certain growth factors that could then contribute to these lesions developing their own kind of microcosm of neurosensory fibers. And we know that when these sensory fibers then become irritated or inflamed within the lesions, we start to see more of this nociceptive pain and overall just heightened nociceptive pain. Things that previously weren't painful are now having this inflammatory response because of the presence of lesions. We also can see a component of peripheral sensitization. So this nociceptive pain that patients may see, the threshold overall then lowers over time with chronicity of this pain. And then we'll start to see the lines get a little bit more blurred where previously non-painful stimuli becomes painful. Oftentimes this will be when patients are coming to you with dysmenorrhea, dyspareunia, ovulatory pain, something that typically isn't usually painful, becomes very acute to these patients, and then eventually can converge into chronic pelvic pain. Another system at play that we believe, especially even in early stage endometriosis, is this cross-organ talk or sensitization, especially when patients are coming with pain that's more diffuse than their lesions may suggest on surgery or on imaging. We know that there is a shared communication between all of the organs in the pelvis, the bladder, the bowel, and then of course the uterus. And this in itself, if there's an inflammatory state of one organ, we may see this visceral sensitization. So where the uterus may be first affected, then the bladder becomes affected, followed by the bowel. In that same neck of the woods, we can also see a visceral somatic convergence of the pain. So maybe where the inflammation or the insult starts at the viscera or at the organ itself, it then may cause referred pain to the somatic structures, such as the skin, the muscles, the fascia. And this is when we tend to see a lot of that pelvic floor dysfunction, pelvic floor muscle involvement, and we'll talk about the particular complaints from that standpoint, and even the abdominal wall, the lower back, the other structures of the somatic system. And then kind of the way to bring it all together, and oftentimes very common with patients with chronic pain, is the phenomenon of central sensitization. I like this image because it just really draws into mind the fact that there are a lot of these things are overlapping, and you tend to not be able to fully evaluate one component without evaluating all the others. And we believe this occurs in some patients, not all, because of this persistent insult, this nociceptive input time after time, month after month, that ultimately will change the way that your body is processing this pain. So think about that nociplastic pain that we spoke about earlier. This typically will present with hyperalgesia, allodynia, again, previously non-painful things being very painful. Patients may come to you with more widespread pain, and then also starts to affect other systems in their life, fatigue, sleep disturbances, things like that. This image does talk about some of the more common conditions that tend to coexist with chronic pelvic pain patients and endometriosis. And this is from a talk from Pain Week, referencing the evil quintuplets. So endometriosis, IBS, pudendal neuralgia, myofascial pain syndrome, bladder pain syndrome. All of these things should be on your mind when you see a patient with chronic pelvic pain, especially complaining that the pain is no longer just confined to the pelvis. So just some factors to consider when you are thinking of central sensitization and why we think that these contribute to it. We talked about this before, but that repeated monthly insult, that nociceptive pain input every single month, that's really uncomfortable for patients. We also know that there is a diagnostic delay oftentimes with endometriosis and treating endometriosis medically, empirically. Coexisting anxiety and depression that may be pre-existing or may occur later in the diagnosis can also amplify this response. Sleep disturbances, pain catastrophization, and then when present, some amplifying factors are also childhood adversity and trauma. So these are things that if you're picking up in your history, they want to clue you into these patients. So just touching on the differential diagnosis of these pain patients. So again, things that we already know and that we're likely already screening for, but making sure that just because it looks like endometriosis, we're not discrediting some other causes. So understanding primary versus secondary dysmenorrhea, discussing this with patients, and doing our proper workup, which we'll briefly touch on, to identify other sources of secondary dysmenorrhea. But not just looking at the gynecologic systems, considering gastrointestinal involvement as well, asking them about their bowel function, screening for things like IBS, constipation, and then getting them to the right referral source if applicable. Urologic systems, again, we talked about the evil quintuplets, bladder pain syndrome, making sure that we're asking patients about these symptoms as well, recurrent cystitis, and then not discrediting or not ruling out that neuropathic pain until we fully assess these patients. Other systems to consider as well, and we'll talk about how we evaluate these, is musculoskeletal etiology. So is there pelvic floor or abdominal wall myalgia involvement? Is there hip or sacroiliac joint dysfunction? Screening these things, sometimes patients have a hard time differentiating them, and so it's our job to do the exam to really help clue us in. Centralized pain conditions as well can be at play, fibromyalgia, patients with migraines, chronic fatigue. And then again, psychological contributors may not be the source of the pain, but can amplify the pain response and clue us into more of these central sensitization patients, like things like anxiety, depression, PTSD, and overall sleep dysfunction and fatigue. So very basic workup. I always start with, history taking and trying to assess a pain phenotype for these patients, because not all patients are going to look the same, and in fact, they're very different. So starting just with a very basic history taking, assessing whether the pain is cyclical versus non-cyclical can often give us a lot of information about which category to put these patients in. Asking for the presence or coexistence of deep dyspareunia, dyschezia, dysuria, low back pain. Again, casting a broader net to look at these other systems that may be involved. And asking about how the pain has evolved over time. Is this something that they've suffered from since menarche, or has progressively gotten worse? Did it start after a surgery or some sort of other factor that may clue us into some of our other types of pain generators? Not forgetting to screen for those other systems that may be involved. So screening for things like IBS may be helpful to get our GI colleagues involved. Asking about symptoms such as bloating, diarrhea, constipation, any sort of bowel incontinence, bladder pain syndrome, pelvic floor dysfunction and dyspareunia, and then also those factors that may clue us into more of a central sensitization patient, fatigue, more generalized pain, and also multiple other pain conditions. And then a lot can be told by a comprehensive physical exam. So I always start with these chronic pain patients with an abdominal exam, looking for those discrete trigger points or areas of hypertonicity that you can really pick up on an abdominal exam. And then also assessing for myofascial pain with the Carnett sign, seeing if their pain is worsened or changed at all with flexion of the abdominal wall muscles. And that sometimes is really telling for patients, and it can be very validating when they find that their symptoms and their pain is actually more superficial and less of a deep visceral type of pain. And then if applicable, surgical scars, always assessing these with a Q-tip test, looking for signs of radiation of pain or allodynia or hyperalgesia, may clue us into an also concurrent neuropathic pain component. I also use the Q-tip for a vulvar external exam before I start with my internal assessment. And this again is assessing for potential pudendal nerve involvement, looking for exacerbated pain response, hyperalgesia, and allodynia of the vulva. And then moving to the pelvic floor exam. So with a single digit, assessing for pelvic floor contraction and muscle potential dysfunction with Kegel strength. And then assessing the levator ani, the ischio-coccygeus, and obturator internus muscles with a single digit to see if there's hypertonicity palpated or pain. And then lastly, moving to our bimanual and speculum examinations to more assess for our typical gynecologic issues, fundal or cervical motion tenderness, etc. I did provide this link, which we'll be able to share later. I'm not going to share it right now, but this is a very comprehensive video made by some of my colleagues that will go through each of these steps and really break it down for you to find a way to integrate this into your practice for these patients. And then very brief, which we're already doing, I'm sure, is just basic imaging, especially for these patients. We want to make sure that even though we think other things may be involved, that we're not ruling out the other sources potentially of dysmenorrhea. So starting with a pelvic ultrasound, it's usually my first go-to as well, just to evaluate for structural lesions. And then more so considering an MRI if I'm concerned about deeper disease or using that for surgical planning. Also other imaging if you're concerned about other pelvic pathology. So how are we going to apply all of these steps and all this information to our clinical practice in an efficient manner? So first, coming up with a pain generator framework. And I'm going to challenge you to start thinking of these patients in a different way. And instead of asking how much endometriosis or how much disease does she have, what stage is she? Instead, you should be asking, what are her pain generators? So yes, endometriosis may very well be involved, and that's a component that we need to address and treat. But are there other sources of inflammation and that nociceptive pain input? Is there peripheral sensitization involved? Are other organ systems also involved? And again, it's the chicken or the egg, but maybe endometriosis is where this all began, but now it's not just what's going on at this point in time. There may be other systems that are involved and need valid treatment. Is there concurrent pelvic floor dysfunction? Is this a patient where I'm thinking she maybe have central sensitization and then I need to consider other etiologies? And beyond these things, what other chronic overlapping pain conditions does she have that need to be addressed? And then just a reminder, this can be very overwhelming with a lot of patients that are coming in wanting answers, chronic pain. And so I think it's important that when we do recognize that there may be other systems at play, other chronic overlapping pain generators beyond just the gynecologic issues, that you don't have to do it all alone, and you shouldn't, because there are other people that have other expertises that these patients can benefit from. So some things that I implement in my practice that I found helpful and that patients have enjoyed and benefited from as well. Early pelvic floor physical therapy involvement. We know this is the gold standard when myofascial pain is found. And so even if surgery does become part of the workup and a part of these patients' treatment, I try and emphasize to them that this is wanting to get you in preoperatively to help establish, and then that you will likely need some sort of postoperative rehab and some sort of chronic treatment. This is a long-standing issue, and so these things can also be helpful for these patients in setting expectations, which we'll touch on a little later. Establishing with GI and getting a diagnosis and ruling out other problems when bowel dysfunction, is identified. Sometimes a preoperative EGD or colonoscopy can really be very telling. And then again, those patients that you're suspecting central sensitization, oftentimes it's an all of the above approach. So they likely will benefit from pelvic floor physical therapy, plus or minus mental health, other forms of integrated medicine if they're open to that. There's lots of benefit from acupuncture, massage therapy, and other modalities. Treating fibromyalgia if that's something that they also have a diagnosis of. And then consider involving pain management colleagues as well if you have a good, reputable team. So what I also want to and am passionate about is making sure that we are all managing expectations appropriately with these patients, especially if surgery does become part of their workup. or part of their therapy. I think that it's very helpful with these patients to validate their symptoms, educate them on the fact that this is a multifactorial nature of their pain and that there may be other things involved. And so all of those things need to be treated, not just treated surgically. Reframing what a successful surgery is, avoiding guarantees at all costs, and then discussing with them the very realistic possibility that this may not completely resolve their pain, or they may have even worsening pain, depending on each individual's risk factors. Some things that I like to tell my patients is that, again, the surgery may improve one aspect of your pain, but not address all pain generators. So we need to make sure we're still doing the work even after surgery. Pain can persist even after a technically successful, uncomplicated procedure. And we're treating a chronic condition, not necessarily curing it. Again, these things are hard for patients sometimes to hear, but I think they're important because they will help them have a better outcome after surgery if that is part of your therapy. So again, just to kind of sum it all together, this is the algorithm that I challenge you to utilize when you have these patients in front of you. First, using your history and physical to really identify their pain phenotype. Assess how much this pain is affecting them and how much that will potentially clue you into what sort of multidisciplinary team you're going to need to assemble. Screen them for overlapping pain conditions, get your mass medical history, and then perform a focused pain exam. You can also assess for central sensitization at that time based off of their medical history. And then again, trialing non-surgical therapies for treatment if applicable, determine their surgical candidacy again, if applicable, and then extensively counsel them before taking them to the OR to make sure that they're aware of all the potential outcomes. So again, to sum it together, early stage endometriosis can produce severe pain because we know pain and stage of endometriosis correlate very poorly correlate. And so these are things we shouldn't just be relying on what stage they are, because we know that that's a significant limitation of these staging systems at this given time. Understanding that neuroinflammatory states, nerve growth can even occur in early stage with just small lesions and microscopic lesions, knowing that these can be highly biologically active and uncomfortable for patients. Understanding that chronic pain tends to involve more than just one system, more than one just diagnosis. And so suspecting multiple pain generators in these patients and screening for them. Understanding that thoroughly evaluating these chronic pelvic pain patients extends beyond just treating the endometriosis. And then again, managing their symptoms and treating them with therapies, as well as educating them. And that can really be helpful in establishing a good relationship. So some action items that I hope you take away for your practice. Again, do not equate endometriosis stage with pain severity and quality of life. That is not a reliable correlation, and it's only one part of the equation. Treat the patient, not just the lesions. I know that as surgeons, that is what we're taught to do, but understanding that endometriosis pain and chronic pelvic pain patients may involve more than one pain generator and may involve more than one therapy. Expect there to be overlap and for the lines to be blurred in these patients. And so screening them for those other system involvements can be very helpful and help you be able to treat them better. Phenotype the pain, not just the disease. Again, looking for other pain generators and doing this very simply with a history and physical. Individualize your treatment and assemble your multidisciplinary team when applicable. And again, if surgery is part of your workup, making sure these patients are counseled properly so that everyone is happy at the end. These are my references, and I think we will take questions at the end. Thank you so much.
Hannah, thank you so very much for that thoroughly encompassing talk about early stage endometriosis. I can tell that you have completely stimulated the participants' curiosity. And we have many questions here that we will get to at the end of both presentations. So everybody keep asking your questions, and we will address both of those sets after the second presentation. Excuse me, but Hannah, that was wonderful. Thank you very much.
Thank you.
Well, our next presenter is somebody I've known very well for the last 32 years of my life. This is Dr. Stephen McCarris, also my husband. Dr. Stephen McCarris currently serves as the Chief of Gynecological Surgery at Advent Health Winter Garden and Medical Director of the Advanced Gynecological Surgery Group in Orlando. Dr. McCarris is widely recognized for his leadership and contributions to minimally invasive gynecologic surgery and the treatment of complex gynecological conditions. And he is going to be presenting today on pain management best practice guidelines. It's yours, Steve.
Okay, thank you, Tammy, for introducing me. Anna, that was a great presentation and really set the framework of what I'd like to build on. My presentation tonight is going to look at some guidelines for treating patients that you think have endometriosis and dealing with pain and the other aspects that come in place with these complex patients. The objectives are, look at a summary of consensus recommendations from expert panels that have been published over the last 5 or 6 years, discuss the burden of endometriosis and complications resulting from delaying the diagnosis, and really look at some shared decision-making management options for these patients, pretty much what Dr. Lewis mentioned in her presentation. Disclosures applicable to this talk are none. So let's look at the impact on diagnostic challenges. Counselors said several decades ago that endometriosis is a difficult condition and very painful for the patient. He also said it's very difficult and painful for the healthcare provider treating endometriosis patients. We do know in a tremendous amount of surveys and data that's been published that endometriosis goes way beyond just dysmenorrhea, it can be dyspareunia, and chronic pelvic pain. And those are the 3 most common symptoms that we hear from patients that come into our offices that complain of pelvic pain. It also interferes with their social life, their work performance, their families, and their activities that they do outside of just menstruation. It really sidelines the patient and really interferes with the quality of her life. Hannah touched on this, and it really is interesting to look at diagnosing endometriosis, and really tonight's discussions are talking about early stage disease. It can take up to a decade to diagnose this, and patients get very frustrated and workups are inadequate. We see multiple different providers and try to figure out why they're having so much pain and feeling so bad. It's challenging to diagnose early stage disease because the symptoms can be coming from different organ systems, as Dr. Lewis mentioned. There's no specific blood test that you can do. On exams and imaging, you may not find any positive findings that would suggest endometriosis. So it really can be a challenge in an early stage patient. In multiple surveys by Solomon and others, it really looks like diagnosing by surgical means takes a longer time to treat compared to non-surgical methods. You might get a diagnosis with surgery, but you delay treatments and pain continues after surgery in some of these patients. It also has been noted that surgery may give some relief for the first 3 to 6 months, but recurrence rates are very high after surgery for the treatment of endometriosis. And one of the things that's been developed in our specialty over the past 5 or 6 years is a minimally invasive gynecological surgery specialist that really focus on the deep dive in endometriosis treatment, whether medically or surgically. Surgery to diagnose early stage disease really does have some questionable action points. First of all, the risk associated with laparoscopy, whether it be straight stick or robotic, and the complications that can be associated with what is considered a very simple procedure to those of us that do that type of surgery. The inability to accurately diagnose endometriosis, the many different types of lesions and locations, and whether it's superficial and deep. The experienced surgeon may be more apt to diagnosing early stage endometriosis than a novice or someone who's been out for just a couple of years out of their training. Lesions can be absent or microscopic, and a negative laparoscopy can be found at the time of a surgery when it could be microscopic disease and the diagnosis is missed. And there's also cost and inconvenience to have surgery. A lot of patients may not be able to afford to go to the operating room because of health insurance issues or taking time from work. So surgery for early stage disease definitely can be questioned, and something that has to be really thought through with that patient on what you're going to get out of doing surgery in a patient who has a negative workup, for example. I was thinking when Dr. Lewis was presenting on the use of pain diaries and collecting data, being able to fast track multi-other organ systems that could be part of the pain complex, and to be able to have real information from the patient on diarrhea, constipation, pain with urination, to be able to document that and bring that up. I'm not sure how many of us really use pain diaries. I think it's a good way to gather information while you're doing initial treatments. And certainly a good physical examination. It's very interesting to me to see how many patients go to our ERs. And we did a data poll at Advent Health here in Orlando on pelvic pain patients that were seen by emergency room physicians that never had a pelvic exam, that the ER physician wasn't comfortable doing that. A consult to a GYN wasn't made, but they always get a CAT scan or maybe an ultrasound that would come back normal, where that patient has nerves that are firing and symptoms that are highly suspicious for endometriosis, but really didn't get a good evaluation. And there have been reputable societies like the European Society for Human Reduction and the Society for Endometriosis and Uterine Disorders that recommend a clinical diagnosis being made on symptoms and workup, and really thinking twice about doing a laparoscopy in early stage disease. And then it gets back to really, again, some of the things that Dr. Lewis touched on, that endometriosis and the cellular connection. What really happens at the cellular level? And I think we all believe that endometriosis is an estrogen-dependent disease. I've never had a patient 10 or 11 years old with endometriosis, and I've never seen a patient 72 years old with endometriosis. But in that reproductive age group where estrogen is being produced, we do see changes at the cellular level, that endometriotic lesions, ectopic endometriosum reacts differently to estrogen than uterine endometrium, that there's an increased aromatase activity stimulating estrogen production at the cellular level. There's this systemic inflammatory change, and all the factors that were mentioned earlier really on high alert. And you notice that in a patient with early stage disease, but you can't image it and you can't fill it on an exam. But her symptomatology suggested that endometriosis could be the culprit in this pain patient. So as estrogen levels stimulate growth factors and prostaglandin release and nerve growth factors and angiogenesis, where there's an invasion of blood vessels to an ectopic implant, there's this inflammatory response. And I think there's a progression from inflammation to proliferation to nerve ingrowth to the implant to blood vessel ingrowth. And there's a factory in that ectopic area of estrogen production, prostaglandin production, and pain at the cellular level. And we have to think about this as a factory that you can't feel or touch or image, but is very, very active, causing pain in that patient. We do know through tremendous amount of data here in the States and even in Europe that in endometriosis early stage pain patients, there's an increased tumor necrosis factor. There's peripheral stimulation of the nervous system. There's nerve growth factor and interleukin 1B increased concentration. And the central nervous system is more sensitive. So this is really, really the opportunity to treat this patient to try to dampen or dilute or decrease all this activity that's causing this systemic inflammatory change that's occurring, really secondary to estrogen production at the cellular level. So we have to think about what's the best treatment to reduce that activity. And what I like to do and what I've really thought about is how do we modulate estradiol production? And Barbieri did this publication, the estrogen threshold hypothesis, which I think is very applicable to how you and I decide what's the best medical management in someone with early stage endometriosis without a laparoscopy, just on symptomatology. So what Barbieri said, in patients that have serum estradiol levels between 30 and 60 picograms per mil, that there's this therapeutic window where endometriosis is not active and pain is very minimal to non-existent. In patients that have serum estradiol levels 50 to 60 or greater, they have pelvic pain, pain with intercourse, and chronic pelvic pain. They have active endometriosis with this systemic inflammatory condition. In patients who have serum estradiol levels 30 picograms or less, they don't have pain from endometriosis or even abnormal bleeding from fibroids. But what they have is bone loss, night sweats, vasomotor symptoms, achy joints, and migraines. So what he proposed that if we can modulate the serum estradiol concentration into that therapeutic window, that's the base case scenario in treating patients with early stage endometriosis. So can you do that with oral contraceptives? Can you do that with certain progesterone medications? Can you do it with a GnRH agonist or a GnRH antagonist? We all know that GnRH agonists really get serum estradiol levels almost to zero. So they don't have pain from endo, but they have vasomotor symptoms. The real newer medications, the GnRH antagonists, are able to modulate. They sit around 30 to 35 picograms per mil. So I want you to remember that when you're choosing a medical therapy and really treating the disease endometriosis, not the symptoms of endometriosis with an oral contraceptive. So treatment guidelines and recommendations from various different expert panels have changed. Now, early on, it's unfortunate that ACOG hasn't updated their endometriosis guidelines in over a decade. American Society of Reproductive Medicine has not as well, but there are some other organizations that have. The European Society for Human Reduction in Embryology, the American Institute for Minimally Invasive Surgery, the group that's putting this webinar tonight, brought together a consensus panel 2 years ago and created and published a best practice guideline for the treatment of early stage endometriosis, as well as the Society of Endometriosis and Uterine Disorders. And I'd like to recap these later organizations, what their recommendations and guidelines are versus some of these older guidelines that you and I kind of grew up with. Guidelines from ESHRE and SUED recommend treatment of endometriosis, empiric therapy with medications, and not performing a laparoscopy in a negative workup patient. That laparoscopy, the yield from laparoscopy is about 35% that you're going to see endometriosis. And it's usually early stage disease in this patient. Their recommendation is to start medical therapy to decrease that serum estradiol level with appropriate medications and follow the patient and see how she's doing over the next 3 months. So empiric therapy with approved medications for 3 months, and then reevaluate the patients. This is endorsed also by the American Institute of Minimally Invasive Surgery. So it brings back the other question that I've always been intrigued by and interested by on what's the correct medication. I mean, I was taught in a negative workup patient, start her on an oral contraceptive with or without nonsteroidal medications. And put her on a pain diary for 3 months. And that is still what I do. I use a low dose oral contraceptives. It decreases and fluctuates the serum estradiol level, inhibits follicular growth. So they're not ovulating. You can do continuous therapy. I never use cyclic therapy. I think continuous therapy makes more sense in a pain patient that you think has early stage endometriosis. About 60% of those patients are going to get better, and that's the goal, improvement of quality of life, take her pain away. So you bring that patient back in 3 months. If she's better, you continue. If she's not, you continue on your algorithm of care. Also, progestin onlys like agestin or norethindrome acetate will impact LH and FSH and will decrease menstruation. I also prefer a progestin only initially to eliminate any extrinsic added estrogen to the patient. Remember, the goal for me is to decrease estrogen production. So I'll usually start on an agestin for 3 months, continuous therapy with a pain diary, and bring her back and reevaluate. I do not start initially with an agonist or an antagonist. And if you look at FDA-approved medications for endometriosis, oral contraceptives are not FDA-approved to treat the disease endometriosis. Neither are progestins, neither are aromatase inhibitors. There's some studies that will show a decrease in pain, but really not decreasing the treatment of ectopic endometrium. The agonist and antagonist are FDA-approved for the treatment of the disease endometriosis, the antagonist for moderate to severe, and the agonist as well. So I'll start out with a low-dose progesterone, bring that patient back in 3 months. If she's not better, I'll re-examine her. If she exam is negative, I will go to a GnRH antagonist. Oral medication gets the serum estradiol level into 30 picograms per meal, right where I want to be. And I'll use a combination antagonist with an estrogen progestin combination pill. See, I want you to really think about getting away from oral contraceptives as a treatment of endo, but going on to one of these newer drugs like a GnRH antagonist. The choice of medical therapy, though, should be tailored and have this discussion with the patient, which medication is the best one for you to use. Again, I will start with a progestin-only contraceptive as a first-line therapy, and then I'll reevaluate in 3 months and switch to an antagonist. I reserve the agonist for my stage 3-4 endometriosis patients, not my early stage disease patients. A couple of comments about surgery. Surgery is surgeon dependent. I've never met or trained two surgeons that operate alike. All surgeons are unique in their approach. Some ablate, some excise, some are aggressive, some are not. Some will do a peek and seek scope. I think surgery is very independent of the surgeon. On early stage disease, the yield is very low from surgery. You've got to excise and get some histology to diagnose it. If that ureter is near the rectum or the ureter, you may drop back. And if you think about it, if you do surgery, then what do you do after surgery? Because we know the recurrence rate of symptoms after surgery is about 65% 2 years after surgery. There's a placebo surgery effect for the first 3 months. That patients will feel better even if you did a sham surgery. When you use medical therapy, the outcomes are all the same. It's not surgeon dependent. So my preference would be in an early stage patient to use a medical therapy and not surgery. So the algorithm that the American Institute published says endometriosis suspected based on clinical symptoms, H&P and exam. Start with a contraceptive medication with or without a nonsteroidal with a pain diary. You bring the patient back in 3 months. If she feels better, you stay on that regimen. If she has pain, you have to reevaluate the severity. If it's mild, I might go to a progestin only or another FDA-approved medical therapy. If it's moderate or severe, I'm going to go to a GnRH antagonist or consider surgery. We all have seen in our practices some patients would rather go the surgery route. That's informed consent and shared decision making. If the decision is go to medical therapy after 3 months of failed previous therapy and the symptoms are moderate or severe, my recommendation would be a GnRH antagonist. Continue on the pain diary and reevaluate that. Follow up every 3 months. This is not a one and done. This is a journey in that patient throughout several years to keep track of how she's doing. If she does well in a GnRH antagonist, you would continue that and see her. If she doesn't do well, you would consider other etiologies, such as the ones Dr. Lewis so nicely presented for us. If you go the surgery route, we recommend excisional techniques. You may want to consider an MRI in the severe pain patient, just in case there's some deep infiltrating lesions on imaging that maybe you couldn't feel on your exam. But what happens after your surgery? If the patient is interested in fertility, then that's the track she would go down. If she's not interested in infertility after your surgery, then the recommendation would be what? You go back on a GnRH antagonist after surgery. There's some good data by, I'm drawing a blank now. Some good data out of Europe looking at excisional techniques plus an FDA-approved medical therapy after surgery is better than surgery alone. So I really feel you've got to get back on medical therapy even after your surgery. And then to wrap it up, from my part, I think it is important to look at shared decision-making, quality of life issues, get the patient involved, other providers involved, other family members involved, and talk the patient that this is a journey. This isn't a medication and we're done, or a surgery and we're done. We need to continue on and let this patient know you're going to be involved with her care. So I hope I've stimulated your thoughts about how I handle these early stage disease patients. We're happy to take any questions.
Well, thank you, Dr. McCarris, for your outstanding presentation. And now I'm going to turn my attention to the questions in our chat. And the first questions are going to be for you, Dr. Lewis. One of our participants wants to know, in your experience, what are the most commonly missed differential diagnoses in these patients?
It's a great question. I think off the top of my head, the ones that I find most patients have never been told about before, and that I may pick up for the first time on my exam, are those musculoskeletal etiologies. So concurrent myofascial pain, either pelvic floor myalgia, tension myalgia rather, or those, we talked about those hypertonicity areas and trigger points and abdominal wall involvement. I think patients oftentimes think that all of their sources of pain are from those visceral sources, that nociceptive pain that we talked about, and are surprised sometimes to find out that, oh, when I'm palpating really superficially, that's the pain that's actually the problem. And so even having patients feel what I'm feeling when they do have a discrete exam finding can be very validating for them. And so making sure that I educate them about that and understand that, the treatment for that isn't necessarily specific surgery and things like that. There are other physical therapies, and getting them involved. Sometimes even muscle relaxants can be very beneficial in those patients. So I'd say the myofascial pain component is probably the most common thing that I see these patients come to me and they've never been diagnosed with before.
Okay, and thank you. And another question for you. How do you differentiate early stage endo from other chronic pelvic pain syndromes, especially when the symptom overlap is significant?
And it's very challenging. And I think that's what Dr. McCarris and I both kind of touch on. I think what I want people to take away from and is that we're not necessarily always in the game of differentiating. I think it's more so being able to figure out what other pain generators are involved in casting a broad net as opposed to pigeonholing these patients into one diagnosis. Sometimes you can get a lot of information just from that history. So going back to whether this is cyclical, non-cyclical pain, thinking more endometriosis with the cyclical symptoms, and then cueing you into potentially other pain generators with non-cyclical pain. So just going back to the basics and our history and physical, I think can really help me differentiate, but trying not to really just pigeonhole patients into early stage endo versus nothing else or everything else and not. I hope that they take away and understand that oftentimes there is much more overlap than I think we realize, even in these early stage patients.
Okay, thank you. And Dr. McCarris, a question for you. How do you decide between hormonal and non-hormonal options?
Well, it depends on the patient's history. Obviously, if she has any contraindications for hormones, we wouldn't go down that track. And then we would go for a non-steroidal anti-inflammatory, and some of the other ones that I have found helpful are the ones used in other specialties, like diclofenac and some of these other non-steroidals that we commonly don't use as OBGYNs. I do like to start with hormonal first, but I don't use estrogens. I go with the progestin only because I feel like the problem is too much estrogen at the cellular level. So I don't want to add any exogenous estrogens to make it worse. So I've used progestins only. Megace is FDA approved to treat endometriosis at high doses, although the side effect profile is not always doable. So I really think some of these newer medications, the interesting thing about a GnRH antagonist, it's a combination pill. So you have where you downregulate LH and FSH, which decreases estrogen production, but it doesn't drop too low. There's a little add back of estradiol and norethindrome acetate in that one tablet. So you're modulating. So that's really the way to go. So you don't have to make the decision between a hormonal or non-hormonal medication.
Okay, thank you. And another question for you. How do you measure treatment success in the absence of clear anatomical disease progression?
I measure success on patients' quality of life measures because that's really what we're after. We're after patients being able to get back into the game, to go to work, do activities, study in college, whatever it is they want to do. That's the biggest measure of success. And then I do like to see these patients every 6 months, and I do a pelvic exam and I ask them how they're feeling. And if she's okay, I'm happy with that. It's a different story if we're talking about endometriomas or kissing ovaries or masses or rectovaginal exam that's tenderness to palpate. Those patients I take to the OR. But after surgery, I go back to a GnRH antagonist.
Okay, thank you. And I'm just noticing, and now it's 8:59, so I'm going to end our discussion and question session. So thank you, Dr. Lewis and Dr. McCarris, for both of your outstanding presentations and for sharing your expertise and insights on the evolving diagnosis and management of early stage endo. Also, thanks very much to Sumitomo Pharma for your sponsorship of this 3-part webinar series. And on behalf of the American Institute for Minimally Invasive Surgery Education, we want to thank you to all of our thanks to all of our participants for joining us this evening and for contributing through the thoughtful questions and discussion. We also want to invite all of you to join us for the second webinar in this three-part series. It's going to be hosted on July 29th, 8 p.m. Eastern Standard Time. The topic will be modern diagnostic testing, changing the algorithm for diagnosing endometriosis. This session will explore emerging diagnostic tools and evolving strategies that are transforming how clinicians evaluate and diagnose endometriosis, with the goal of reducing delays in diagnosis and improving patient outcomes. Please mark your calendars and plan to join us for what promises to be another informative and engaging discussion. And again, thank you for your participation. We look forward to seeing you again on July 29th, and have a wonderful evening. Thank you.